Alright guys, good evening. Hi Osama, good evening. Can you all hear me? Can you all see me? Good evening, good evening. Can you all hear me? Can you all see me? Hi, good evening Anil. Right. So, कल का जो discussion था, we spoke about the various types of shock and we told about how to interpret it and look up across the components of shock. For the hypovolemic shock, we have already discussed in our trauma lecture that how do you do a fluid resuscitation, what are the protocols, and how do we take it further from there. Hi Nisham. Right, so good evening guys. So today it is going to be one of the most important lectures in the management of shock, and that to be the management of septic shock. Now this is the shock that you will come across many a times when you're working as a resident or an intern and you have to manage a patient, especially in ICU, right? Now the septic shocks have various causes. It can be because of, see, at the end it has to be some infective foci. The source of infective foci can be from anywhere. It could be from trauma, it could be from, let's say, a ventilator. It could be because of pneumonia. It can be because of UTI. It can be because of peritonitis. It can be anything which is going to result in infectious foci. And that foci will result in shock. And that shock will cause the foci of sepsis. Okay? Right. So today, I will be specifically talking about in detail about the concepts of septic shock. Now this video that we are going to do today, I want you to save this video. I want you to bookmark this video or just, put it in your library, because into your practice as you become resident, as you become an intern, जब भी septic shock को manage करना है, you will refer back to these guidelines, and I'll be talking about the surviving sepsis guidelines, which is an update from 2024. All the new points about the sepsis guidelines will be covered. ठीक है? चलो, so अनिल कौन सी क्लास है? दिस इज जनरल सर्जरी क्लास. ठीक है, दिस इज फॉर MBBS स्टूडेंट्स आर प्रिपेयरिंग फॉर देयर नीट PG एग्जाम. अब ये बोलना पड़ रहा है, ये इटसेल्फ इज क्वाइट इंट्रीग्ड. ठीक है, चलो, लेट्स नॉट वेस्ट एनी फर्दर टाइम. So in order to understand septic shock, we have to understand few terms that we are going to use it very casually. The first term that we say that we are going to talk about sepsis, right? Now, what is sepsis? This has been something that we all should understand. So sepsis is what we call it as. Sepsis is what we call it as a patient who is going to have systemic inflammatory response syndrome, that is SIRS, with known foci of infection. With known foci of infection. So whenever I will use the word sepsis, sepsis is a condition. Sepsis is a condition where you have a patient with systemic inflammatory response syndrome. SIRS stands for systemic inflammatory response syndrome. It is your systemic inflammatory response syndrome. So how do you know a patient is landing up in SIRS? See, known foci of infection, yes, you should identify from where the infection is there. Is it a wound, or is it a pneumonial patch, or it is some patch in the lung, or it can be because of peritonitis, it can be secondary to UTI. So you need to know from where the foci is going to be present, right? Now, when you talk about what is the criteria to call the patient is having a systemic inflammatory response syndrome, the criteria that decides the patient is in SIRS per se, the first one is going to be the body temperature. Now, if the body temperature is less than 36 degrees Celsius, that is hypothermia, or more than 38 degrees Celsius, which indicates fever, that is the first criteria. Either it is less than 36 degrees Celsius or it is more than 38 degrees Celsius. The second criteria is the heart rate. You will see if the heart rate is more than 90 beats per minute. If the heart rate is more than 90 beats per minute. After heart rate, you will look at the respiratory rate. If the respiratory rate is more than 20 cycles per minute, if it is more than 20 cycles per minute, or in simple words, I can say if the partial pressure of carbon dioxide, that is PaCO2, is less than 32 millimeters of mercury. So either the body temperature is less than 36 or more than 38, heart rate more than 90, respiratory rate of more than 20, and the last criteria is your WBC count. Either it is less than 4,000 cells or it is more than 12,000 cells, right? So either it is less than 4,000 or more than 12,000, it is indicative of SIRS. Now, in order to call the patient is having systemic inflammatory response syndrome, you have seen the 4 criteria that you have mentioned. If any two of them are positive, then I can say the patient is having systemic inflammatory response syndrome. So currently we say more than or equal to 2 criteria if they are positive. Any 2 of them are positive or more than 2 of these criteria are positive, patient is now said to have in systemic inflammatory response syndrome. Okay. The other terms that we're going to introduce, and then we'll take it as it continues to go forward. Now there's another word which is called as the septic shock. So we learned the word what is called as sepsis. फिर एक और word आता है which is called as septic shock. Now what is septic shock? Septic shock is defined as sepsis. It is sepsis with hypotension. It is hypotension. Now what is so significant about this hypotension? This hypotension is non-responsive to fluid resuscitation. This hypotension, it is not responding. It is not responding to fluid resuscitation. It is not responding to the fluid resuscitation. So sepsis with hypotension is what we call it as septic shock. Another term that is interchangeably used is what we call it as MODS. MODS stands for multiple organ dysfunction syndrome. This is what we call it as multiple organ dysfunction. It is a multiple organ dysfunction syndrome. So currently we say MODS is something where more than or equal to 2 organs fail at the same time. Fail at the same time. If more than or equal to 2 organs fail at the same time, if more than or equal to 2 organs fail at the same time, this is what is called as MODS, right? So हमारे पास criteria क्या है? Number 1, it is sepsis. Number 2, it is septic shock. Number 3, it is what we call as MODS. Again, a very, very important concept that you need to understand that अभी जो हम criteria लेके चल रहे हैं वो SIRS का criteria नहीं है जो मैंने अभी आपको पढ़ाया है, that is systemic inflammatory response syndrome. It is now replaced by SOFA and Q-SOFA scores. वो आगे जाके पढ़ेंगे, but this is the initial presentation that you need to understand, right? If you have understood the basic definition कि आप sepsis किसको बोलते हैं, when do you call it as a patient is in septic shock, what do you mean by MODS, let's understand when would you call a patient to be in severe sepsis. When would you call the patient is in severe sepsis? Now this is where you are going to step in as a resident or as an intern, that you're trying to treat a patient and see what best the outcome can be, right? So when we say severe sepsis, it is classically defined as, severe sepsis is classically defined as sepsis. So there has to be sepsis with some degree of organ hypofunction. With some degree of organ hypofunction. That means deteriorated or decreased function of that particular organ has to be there, right? So in that you need to understand, that severe sepsis is a criteria where we say patient is having sepsis with some amount of organ hypofunction. So how do you interpret that? The first one, we look at the cardiovascular system, which is the most important system. The criteria here is going to be systolic blood pressure. If it is less than or equal to 90 millimeters of mercury. In fact, this is the criteria to say patient is in hypotension per se. Apart from that, rather than, when you look at systolic blood pressure, you're looking at only one single pressure. But vessel have two pressures, systolic and diastolic, right? So you need to have an average of both, and that is what we call it as the mean arterial pressure, where I'm saying we are getting 1/3 of the systolic blood pressure with 2/3 of your diastolic blood pressure is taken into consideration. And if the MAP is less than or equal to 70 millimeters of mercury. So the first criteria to say the patient is in severe sepsis is on the cardiovascular system base, and that is going to be based upon the systolic blood pressure and the mean arterial pressures, right? Now it is all responsive, okay? It will respond to the fluid management, so don't worry about it. The second is your renal criteria. Now, in the renal criteria, the most important thing that I would be looking across is the urine output. It is going to be the urine output. If the urine output is going to be less than 0.5 ml per kg per hour. If it is less than 0.5 ml per kg, it is going to be less than 0.5 ml per kg per hour. That is going to be considered as the decreased urine output, or I can say it is going into a state where it is going to become oliguric. Okay? Now, this another very important point, ये जो urine output है, this is despite. So whenever we say all these pressures are talking about, this is despite fluid resuscitation. Despite giving fluids. So this is also despite giving fluids. So even after giving fluids, the systolic blood pressure remains less. The MAP, that is mean arterial pressure, also remains less. The urine output also remains less. Okay? Now, the third criteria that you have, is of the respiratory criteria. The third criteria that you have is of the respiratory criteria. Now, in the respiratory criteria, I'll be looking at the partial pressure of oxygen. The partial pressure of oxygen to the ratio of FiO2, and that is going to be, if it is less than or equal to 250, indicates of respiratory failure. Okay? So you have the cardiovascular system, you have the renal system, you have the respiratory parameters, then your that is hematological, that is hemoglobin. So hematological parameters that you need to know. The hematological parameters that you have, number one is the platelet. If the platelet count is less than 80,000, it indicates severity, right? And especially if the decrease of the platelets are in decreasing trend, you need to be more worried. Now, the last one is going to be the metabolic status. It is the metabolic status. In the metabolic status, needless to tell you, I will be looking at the pH of the patient. If the pH is going to be less than 7.3 or the base deficit, is more than or equal to 5, this indicates the patient is drifting into severe sepsis. Okay? So what is the criteria to call a patient is going to have severe sepsis? तो जब भी आप काम कर रहे हो किसी भी ward में, if you are working in any casualty or any emergency setup or an ICU, these are the parameters that you have to keep a look at. ठीक है? So जैसे ही आप casualty में walk करोगे और you go into an ICU, you look at the patient's monitor. जब आप पेशेंट का मॉनिटर देखोगे, ऑब्वियसली आप प्रेशर्स देखोगे. तो सबसे पहले सिस्टोलिक ब्लड प्रेशर अगर 90 से ऊपर है, कोई दिक्कत नहीं. फिर आप उसका जो अगर कैथेटराइज पेशेंट, आप यूरिन आउटपुट देखोगे. यूरिन आउटपुट कैलकुलेट करोगे कितना है. यू शुड नो द वेट ऑफ द पेशेंट. इफ इट इज लेस देन 0.5 ml, वरी सम है. मोर देन 0.5, नो नीड टू वरी. रेस्पिरेटरी रेट आप देख लोगे इन टर्म्स ऑफ PiO2, द पार्शियल प्रेशर ऑफ ऑक्सीजन इन द रेशियो ऑफ FiO2. इफ इट इज मोर देन 250, नो नीड टू वरी. लेस देन 250, यस देयर इज अ कंसर्न. ठीक है. फिर आप प्लेटलेट देखोगे, अगर प्लेटलेट में कोई ड्रॉप नहीं, यू नीड टू वरी. इनफैक्ट वी से if the platelet drop is more than or equal to 50% of its initial value, अगर initially 3 लाख है, फिर आप देख रहे हो next within few hours, if it is going to 1,50,000, that is some worrisome point. But we say the baseline is going to be at 80,000. We take the baseline to be at 80,000. And last is the pH. If it is less than 7.3, that is why ABG comes very, very important and handy in these patients. Okay? So this is what we call it as the severe sepsis criteria. बट अभी क्या हुआ है ना, सब कुछ ऐसे हॉच पॉच हो गया. तो क्योंकि इतने सारे इंटरमिक्स क्राइटेरियाज हैं, नाउ वी हैव समथिंग क्वाइट इंपॉर्टेंट, दैट इज which is replacing all these criteria, which is called as the SOFA score. Okay? Guys, you need to understand that all these criteria that we're talking about are a well-versed criteria and then build up over a year. So ye criteria are actually going to save the patient's life. If you are a good doctor, you will look at these parameters and try to alter your treatment and management so that you can come up with a better outcome for the patient, right? It is going to be for a better outcome of the patient. Now, all those students who are preparing for your Neet, that is 2025, which is going to be in the mid-June, we are at a very crucial junction in our Neet preparation. ये जो आखिरी के 6 महीने हैं, this is going to be quite important and crucial, and especially those students who have just finished their counseling and let's say you have not gotten the seat that you have desired, right? Let's say you missed out on few opportunity or due to some XYZ reason you're not taking a seat this time. Do not lose your hope, because this 6 months are very, very important and crucial. In fact, the पहले के 6 महीने समझने में लग जाते हैं, आखिरी के 6 महीने जो दौड़ लगाता है, whoever is able to put its maximum effort wins the race. Abhi se start getting your preparation on a serious track. Get to a point where you are able to consolidate your material. Follow one single source material. Try to read and revise it. Start doing questions. Get in a habit of doing questions. In fact, any topper who I've spoken to in last 5 years, everybody had one single thing to say, कि sir, daily questions करना important और mandatory है. If you do 100 questions per day in 6 months period of time, you will easily cross a mark of 10,000 questions, and that is the benchmark you're looking to crack an exam. Okay? So do not leave on that. Now, on that note, we'll talk about something called as a SOFA score. Now, what does the SOFA score basically stands for? SOFA says it is the assessment that is your sequential organ failure assessment score. So whenever you have a patient who is in sepsis, so slowly you will see the organs tend to fail because of hypoperfusion, right? But I need to keep a tab that how or why these organs are failing, and then how do you know whether the organ is failing or not? So you have a criteria, that is what we call it as the SOFA score, right? So in order to assess the SOFA score, we give the scores of a score of 0, a score of 1, a score of 2, a score of 3, and a score of 4 is given. So these are the maximum scores that you give in a patient who is going to have a SOFA score criteria. Now, what are the systems that you're going to look across? Now, systems that we are going to consider when you're scoring for a SOFA scoring system. The first system, it is going to be your respiratory system. It is going to be our respiratory system. So when you're considering the respiratory system, so I will be measuring what we call it as the partial pressure of oxygen, and this I will be measuring in kilopascals, right? If the partial pressure of oxygen, one second guys, okay. If the partial pressure of oxygen is more than or equal to 400 kilopascals, a score of 0 is taken into consideration. If it is between 400 to 300, a score of 1. If it is between 300 to 200, it is a score of 2. If it is between 200 to 100, a score of 3. If it is less than 100 kilopascals, a score of 4 is given. तो पहला आपने देख लिया हमारा partial pressure of oxygen. Second thing, you will measure something called as the FiO2, and this is measured in millimeters of mercury. Okay? Now, this translates if FiO2 is more than or equal to 53.3, right? If it is between 53 to 26, if it is between 53 to 26, a score of 1 is given. If it is between, 53 to 40, not 26. 53 to 40, if it is 40 to 26, if it is 26 to 13, and if it is less than 13, right? Same criteria that you have. So the first that you have considered is your respiratory system to look at the scoring component. The second one that you will look at is the coagulation. Now for the coagulation assessment, I will look at the platelets. If platelets are more than 1.5 lakhs, a score of 0 is given. If it is between 1.5 to 1 lakh, a score of 1 is given. If it is between 1 lakh to 50,000, a score of 2. If it is between 50,000 to 20,000, a score of 3. If it is less than 20,000, we say a score of 4 is going to be given. That is in the context of platelets. Okay? So this is your look in the coagulation status. Then you go to the liver. So in the liver, I will measure bilirubin. I'll measure the bilirubin, and that is going to be in milligrams per deciliter. It is going to be in milligrams per deciliter. If the bilirubin is less than 1.2, it is considered to be a score of 0. If it is between 1.2 to 1.9, a score of 1. If it is between 2 to 5.9, a score of 2 is given. If it is 6 to 11.9, a score of 3 is given. And if it is more than or equal to 12, a score of 4 is given. I'm just slightly crammed up for space. I'm going to move all this here. Okay. Right. So this is in the context of liver, or I can say in the context of bilirubin. Okay. So that's your liver criteria. Then in the context of cardiovascular system, we look at the cardiovascular system, CVS. So in the cardiovascular system, I'll be considering the mean arterial pressure, that is MAP. A MAP of more than or equal to, so MAP will be measured in millimeters of mercury, right? So if it is more than or equal to 70, a score of 0 is given. Less than 70, a score of 1 is given. If it requires dopamine for maintaining the MAP, if it requires dopamine and that is less than 5, that is going to be in terms of milligrams per deciliter, a score of 2. If dopamine requirement is anywhere between 5 to 15. So here we say dopamine is required, but here dopamine requirement is anywhere between 5.1 to 15. And if the dopamine requirement is going to shoot for more than 15, a score of 3 is given. A score of 4 is given if the dopamine is more than that of 50. Okay? So that is on the basis of cardiovascular system. Then comes your CNS system. So CNS ke liye we will be considering the GCS of the patient. A score of 15, we say a score of 0 is given. Between 13 to 14, a score of 1. If it is anywhere between 10 to 12, 6 to 9, less than or equal to 5. Then it will become a score of 4. That is in the terms of CNS. Okay? The last parameter that I would consider is going to be the renal parameter. It is going to be the renal parameter. So in the renal parameter, you have two things that you'll consider. Number one is serum creatinine and urine output. So you will consider the serum creatinine as well as the urine output. ठीक है? तो serum creatinine, if it is less than 1.2, then कोई problem नहीं है. If it is between 1.2 to 1.9, a score of 1. If it is between 2 to 3.4, a score of 2. If it is between 3.4 to 4.9, a score of 3. More than or equal to 5, a score of 4 is given. Urine output here, we say it is normal. Normal if it is less than 500 ml in 24 hours. It is 500 ml in 24 hours. It is a score of 3 is given. If it is less than 200 ml in 24 hours, a score of 4 is given. ठीक है? I know it's a slightly extensive table, but trust me, every single point that we have learned here is going to be important from our exam perspective. I'm not going to emphasize again and again, but SOFA scoring system is something that I would expect every single intern or a resident to know when he walks up into my casualty. तो अगर आपको सोफा स्कोर असेसमेंट आता नहीं है तो आप पेशेंट कैसे असेस करोगे, ठीक है. सो पेशेंट असेसमेंट के लिए ये जो स्कोरिंग क्राइटेरिया मैंने आपके सामने दिया हुआ है, दैट इज़ द वेरी वेरी इंपॉर्टेंट क्राइटेरिया. इनफैक्ट यू आर राइटिंग योर नीट एग्जाम, नो दिस प्लेज अ वेरी वेरी इंपॉर्टेंट कॉम्पोनेंट एंड अ रोल, ठीक है. सो जितना भी so whatever we have tried to summarize that, I've tried to keep it in a very uh, easy way to remember it and understand it. So this is going to be in a breakdown of system wise, otherwise पूरा hodgepodge data लगता है, ठीक है. एक दो बार रिवाइज करना पड़ेगा, but trust me, once you do so, you will be able to remember every single component of your SOFA scoring system. तो SOFA score में ना, rather than trying to remember all these numbers as jig numbers है, एक बहुत सिंपल सा कॉन्सेप्ट है. तो सोफा स्कोरिंग में क्या क्या देख रहे हो, अगर आप ऊपर से नीचे देखो सब कुछ इन्वॉल्व है. सीएनएस इन्वॉल्व है, सीवीएस इन्वॉल्व है, रेस्पिरेटरी सिस्टम इन्वॉल्व है, रीनल इन्वॉल्वमेंट इज देयर एज वेल एज हेपाटोबिलियरी, दैट इज योर लिवर इज देयर, ठीक है. सो ऑब्वियस सर्कुलेशन में हेमाटोलॉजिकल क्राइटेरिया इज देयर. रेस्पिरेशन में हम देखेंगे दैट इज पार्शियल प्रेशर ऑफ ऑक्सीजन. यू डोंट नीड टू रिमेंबर द FiO2 वाला क्राइटेरिया, रिमेंबर द पार्शियल प्रेशर ऑफ ऑक्सीजन वाला क्राइटेरिया. 0 more than 400 is considered to be 0 and less than 100 is considered to be 4. अगर आपको ये दो डेटा पता है ना, इन बिटवीन डेटा यू कैन प्रेडिक्ट दिस स्कोर, तो ज़्यादा उसमें दिक्कत नहीं होती है. तो if I say a partial pressure of oxygen, if it is more than or equal to 400, score of 0. If it is less than 100, a score of 4 is given. प्लेटलेट्स का क्या है, more than 1.5 is normal, less than 1.2. तो I will always say score of 0 to be remembered and a score of 4 has to be remembered. Bilirubin का again less than 1.2 is considered to be score of 0. इस 1.2 में से अगर पॉइंट निकाल दोगे ना तो 12 बन जाएगा. सो मोर देन और इक्वल टू 12 अ स्कोर ऑफ 4. इन बिटवीन वाला वैल्यू इन बिटवीन में आ जाएगा, ठीक है. मैप, नो नीड टू वरी अबाउट इट, ये सबसे आसान रहेगा. मैप ऑफ मोर देन 70 इज रिक्वायर्ड, लेस देन 70 इज अ स्कोर ऑफ 1. अगर वो आइनोट्रोपिक सपोर्ट पे, डोपामीन पे है, लेस देन 5 स्कोर ऑफ 2 is given, 5 to 15 is score of 3, more than 15 requirement, a score of 4 is given. GCS का again it's a decreasing trend, everybody knows it. Creat का याद रख लेना, less than 1.2 is equal to score of 0, more than or equal to 5 is what we call it as score of 4. अगर आप देखोगे बिलिरुबिन और क्रिएटिनिन का स्कोर 0 is equal, लेकिन बिलिरुबिन का 12 becomes a score of 4, क्रियाट में 5 becomes a score of 4. That's it. यही चीज़ें याद रखनी है, इससे ज़्यादा याद रखने की ज़रूरत नहीं है. एंड व्हेन यू ट्राई टू एनालाइज अ पेशेंट बिटवीन दीज कॉम्पोनेंट्स, नो, यू विल नेवर गो रॉन्ग, ठीक है. नाउ अगेन वी से इफ एनी 2 इज गोइंग टू बी पॉजिटिव, सोफा में वी से more than or equal to 2 is positive, it indicates increased risk for mortality. It increases the risk for mortality, as simple as that. लेकिन वही है कि अभी ऑल योर जेनजी किड्स नो, आप बोलते हैं कि सर इतना सब कुछ याद रख नहीं सकते, तो इसके शॉर्टकट के लिए हमारे पास एक और क्राइटेरिया है, उसको बोलते हैं क्यू सोफा स्कोर. क्यू सोफा स्टैंड्स फॉर, क्यू स्टैंड्स फॉर क्विक सीक्वेंशियल, इट इज क्विक सीक्वेंशियल ऑर्गन फेलियर असेसमेंट स्कोर. ऑर्गन failure assessment score, right? The Q SOFA stands for quick sequential organ failure assessment score. So इसके criteria क्या क्या हैं? If you look at the Q SOFA scores, it is, we have GCS as a criteria, we have respiratory rate as a criteria, and we have the systolic blood pressure as the criteria. So हम बोलते हैं कि अगर कोई भी ऐसा patient है जिसका GCS is less than 15, that is presence of altered mental sensorium, ठीक है. GCS of less than 15, respiratory rate was more than or equal to 22, and systolic blood pressure of less than or equal to 100, ठीक है. This is your cycles per minute and this is your millimeters of mercury. Again इन तीनों में से any 2 is positive. If any 2 out of 3 is positive, there is an increased risk for mortality. there is an increased risk for mortality. ठीक है? So this is how you assess the SOFA and the Q SOFA scoring systems. Clear है? ठीक है? So I hope everybody is clear with what is called as sepsis. See, all these, no, they look a little bit dry, but every single component and system, I mean, the concept that we have discussed is quite important. You should know what is sepsis. You should know what is septic shock. You should know what is MODS. You should also know what is severe sepsis ka current criteria. Now that is replaced by the SOFA criteria. We should also know what all includes in the SOFA criteria. And then you have the Q SOFA scoring system as well. So all these are considered to be an assessment tool. So we have something called as new criteria. तो अगर आप मेरी क्लास में आए हो तो लेटेस्ट चीज़ें नहीं पता करोगे तो फिर कैसे चलेगा? ठीक है? So one thing that I can assure you is every single time I come up with a topic, I will teach you that topic to that date which is updated. उस दिन जो update और जो चीज़ें चल रही हैं आपको वही चीज़ें पढ़ाएंगे. So there is nothing. I'll also give you the older protocols. पुराने protocols के साथ नया protocols भी पढ़ाऊंगा ताकि you should know that what is changing and why are we changing. So rationale behind change is also quite important. ठीक है? Now, when you talk about the newer criteria, in the newer criteria, right, when we say the word sepsis, now sepsis is now what we call it as a life-threatening. It is now what we call it as a life-threatening organ dysfunction. This is a life-threatening organ dysfunction. This organ dysfunction, it is caused by, so it's a life-threatening organ dysfunction. It is caused, or the basic reason, it is caused by dysregulation. This is caused by dysregulation of host response, of the host response to inflammation. To inflammation. Now, all the students who have attended my class yesterday, we spoke about in septic shock, what is the problem? There is loss of peripheral vascular resistance. And due to that loss of peripheral vascular resistance, patient now lands up with life-threatening organ dysfunction. Now, this is usually caused by the host response or dysregulated host response, which is in response to the inflammatory component that is there, right? Now, when we say organ dysfunction, when we use the word organ dysfunction, the word organ dysfunction is quite casually used, but I would like to give you a very precise answer for this. That is identified as an acute change. If there is an acute change, if there is acute change in total SOFA score, in the total SOFA score, by more than or equal to 2 points. If there's an acute change, that is sudden increase in the score, initially SOFA was 1, it has suddenly become 3. So more than or equal to 2 points of change with evidence of infective foci. With evidence of infective foci, then I would say the patient is having organ dysfunction in this criteria. Okay? Right. What is the mortality when you have a SOFA of 2? Remember, a SOFA score of more than or equal to 2 usually indicates 10% risk for mortality. Right? It indicates this 10% risk for mortality. Now, as the SOFA score continues to increase, the risk for mortality also continues to increase. Right? So let's look at पुराना जो old हमारा criteria है, and I'll also superimpose that with the new criteria. हमारे पास जो definitions है that we have to look across. Number 1 is sepsis. Number 2 is your severe sepsis. And the third one is what we call it as the septic shock. So we have sepsis, we have the severe sepsis and the septic shock. Now, the older answer for sepsis was patient who's having systemic inflammatory response syndrome with known foci of infection. With known foci of infection. Now, as I told you, SIRS is an old concept. So currently we do not follow SIRS. SIRS is an old concept. Systemic inflammatory response syndrome is not considered to be a criteria anymore, right? So what do you consider now? So here now we say, if you have a patient who is having a Q SOFA or a SOFA score which is more than or equal to 2 with known foci of infection, this is what we call it as sepsis. So currently you need to remember that SIRS is out, SOFA and Q SOFA are in. So currently whenever we talk about the word septic or sepsis per se, in sepsis we do not consider SIRS any longer. Now it is purely replaced by SOFA and the Q SOFA's component. What is severe sepsis? Now severe sepsis is a term. Severe sepsis is a term that describes the patient is having sepsis according to the older definition. Along with sepsis, the patient has hypotension. Patient also have hypoxia. There will be increased serum lactate. Plus end organ dysfunction. If all these are present, as we have just described it, that is what we call a severe sepsis. Remember, this category according to the new criteria does not exist. Either there is sepsis or there is septic shock. We do not have severe sepsis. That is currently out of the foci. Now, older definition for septic shock. So what do you mean by the septic shock? Septic shock is sepsis. It is sepsis with hypotension, not responding to fluids. It is not responding to IV fluids, right? Now, what is the severe sepsis according to the newer guidelines? Here, sepsis according to the new guidelines. That means no SIRS. Here you're talking about Q SOFA score or SOFA. Plus, if the patient is using vasopressor. If the patient is on vasopressor support and if the serum lactate is elevated. If this is present, this is what we call a septic shock. Okay? So now the criteria are quite simple. Purana wala chodo. Naya wala is what we are supposed to take into consideration. So old or new criteria mein, you need to be absolutely clear. Purane mein hum all these terms were used. Now we don't have them. Okay? So now we don't have the term which is called as severe sepsis. Either we have sepsis or we have septic shock. And these are the points that you need to remember in favor of every single point that we have discussed. Okay? So do not forget about these criteria. Okay? The reason why I'm keeping the notes quite clean, because this is the same annotated PDF that I'll be sharing in our Telegram group or in our notes class group or in our PW MedEd group, so that you can revise them whenever you want to. This is going to be your referral. So this is the data that I've collected not only from Bailey but also from Sabiston, from Washington Manual of Surgery. You have the Fisher's Mastery of Surgery. All these books we have collected a data and try to comprehend in one single lecture so that you can benefit out of it. So this is the old and the new criteria. अब से हम सिर्फ और सिर्फ न्यू क्राइटेरिया पे फोकस करेंगे. सेप्सिस और सेप्टिक शॉक, देयर इज नथिंग कॉल्ड एज सिवियर सेप्सिस, राइट? इट इज कॉल्ड एज सिवियर सेप्सिस. क्लियर है? ठीक है. अब इतना सब कुछ तो पढ़ा दिया. अब बारी आती है कि वार्ड में करोगे क्या. सो व्हाट इज द इनिशियल रिससिटेशन प्रोटोकॉल? व्हाट इज द इनिशियल रिससिटेशन? व्हाट इज द इनिशियल रिससिटेशन प्रोटोकॉल? तो ये जो इनिशियल रिससिटेशन प्रोटोकॉल है ना, इनके बड़े सिंपल से गाइडलाइंस है. विल फॉलो दैट, राइट? The first one, that is this is the goal that is set for first 6 hours of resuscitation. So this is the goal that is for the first 6 hours of resuscitation. So when you receive a patient and you make a diagnosis that the patient is in septic shock with all the criteria that we have laid down, जैसे ही patient को हमने septic shock में पाया तो पहले 6 घंटों में क्या करोगे? The goal is quite precisely set. The first thing that you will do is to measure the central venous pressure and CVP हमारा 8 to 12 millimeters of mercury पे maintain कर रहा है. देखो central venous pressure is not an absolute pressure. Normal CVP can be 5, can be 9, can be 13, it could be any number, it does not matter. But what it matters is when I'm giving fluid or when I'm resuscitating the patient, is the CVP increasing or not? If the CVP increases and it falls into this range, that is 8 to 12 post-resuscitation, we say CVP is normal, it is called a responsive shock. But if you keep giving fluids and the CVP does not increase or it does not show any improvement in trend, that indicates it's a non-responsive shock. So CVP हमें ये नहीं बताता कि पेशेंट नॉर्मल है कि एबनॉर्मल है. पेशेंट को हम CVP हमको ये बताता है कि जो फ्लूइड आप दे रहे हो वो फ्लूइड बॉडी में रिटेन हो रहा है कि नहीं हो रहा है. जैसे ही फ्लूइड दोगे अगर सर्कुलेशन में रिटेन होगा तो CVP राइज करेगा. इसका मतलब है वो जो वॉल्यूम आपने बाहर से दिया है वो वेसल के अंदर प्रेजेंट है. आई रिपीट अगेन, CVP tells you whether you have a patient with responsive or a non-responsive shock. Once you start giving fluids, if you see there is jump in CVP, that indicates the fluid is getting retained into the intravascular volume, which is a good sign. लेकिन अगर आप fluid दे रहे हो CVP increase ही नहीं हो रहा, मतलब क्या हो रहा है? Fluid दे रहे हो, it is not able to increase the pressures inside the vessel. Either the vessel is too dilated, that happens in septic shock, or there is some leak where the volume is going down, or it is a combination of both. ठीक है. So a CVP if it is not responding on resuscitation is a poor sign. तो मेरा टारगेट होगा कि CVP बढ़ाना है. ठीक है. So CVP should be maintained at 8 to 12. Second target is to have an adequate perfusion with mean arterial pressure, and the MAP का जो goal है it should be more than or equal to 65 millimeters of mercury. I told you earlier also, in order to not only MAP, we have something called a cerebral perfusion pressure. The minimum CPP required to perfuse the brain is 60. ठीक है. तो MAP 65 के ऊपर रखना ही रखना है, वरना perfusion to brain will decrease. The third criteria is the urine output. This has to be maintained at more than or equal to 0.5 ml per kg per hour. इससे कम में मैं बात मानूंगा ही नहीं. ठीक है. तो यूरिन आउटपुट इतना मेंटेन करना ही करना है. इफ यू आर कीपिंग द पेशेंट इन एन ICU, then you will look for mixed venous oxygen saturation. The mixed venous oxygen saturation should be maintained between 65 to 70%. 65 to 70% ये हमारा टारगेट है. And then maintain, we have to make sure the serum lactate is to be reduced to normal level. It should be reduced to normal level. It should be reduced to that of normal level. ठीक है. If all these are achieved, you say you get a responsive patient. Yes, a patient of all this. Okay, I'll keep it in a simple context. Let's say imagine you have a patient who has landed with septic shock. ठीक है. कोई भी patient septic shock के साथ आता है उसको आप fluids या any patient of shock per se, I'll give IV fluids. तो IV fluids में resuscitation में I will usually go with crystalloids because you know they are rapidly infusible. If not, then colloids if it is not responding. Colloids maybe I will prefer albumin if I have to give, and crystalloids में I will prefer ringer lactate over normal saline. ठीक है. इसके ऊपर भी हमारे पास discussion, will talk about it. Imagine that after giving IV fluids, if the patient, as we say, the word septic shock indicates what? Fluid देने का भी respond नहीं करेगा ना. So when the patient is not responding, so let's say patient is not responding. We say patient is not responding to IV fluids. ठीक है. अब why the patient is not responding? Again, we have a very simple concept. Septic shock में problem क्या है? Septic shock is a type of distributive shock. जो भी आप वॉल्यूम दोगे इट विल गो इनटू ऑल द नूक एंड कॉर्नर्स ऑफ द बॉडी बिकॉज इज यूनिवर्सल वेसोडाइलेशन. कितना भी वॉल्यूम दोगे वो डिस्ट्रीब्यूट हो जाएगा. इट इज नॉट गोइंग टू गो टू द वाइटल ऑर्गन्स और द वॉल्यूम इज नॉट गोइंग टू रिटेन इनटू द सेंट्रल कंपार्टमेंट टू हैव इनफ अमाउंट ऑफ प्रेशर. सो जिसकी वजह से सारे ऑर्गन्स हाइपो परफ्यूज ही रहेंगे. तो अभी मुझे क्या करना है? मुझे पेरिफेरल वैस्कुलर रेजिस्टेंस रिस्टोर करना है. मुझे वेसल जो डायलेटेड है उसको वापस नॉर्मल लेके आना है. सो आई हैव टू कॉज वेजो कंस्ट्रिक्शन. सो आई हैव टू टेक फॉर आइनोट्रोपिक सपोर्ट. I have to take these patients for the inotropic support, so I will give vasopressors if the patient is not responding to fluids. अगर रिस्पॉन्ड नहीं कर रहा है, यहाँ पे हम पेशेंट को स्टार्ट करेंगे वेजोप्रेसर पे. So this is where we'll start the patient on vasopressors. तो वेजोप्रेसर्स ना अपनी मर्जी से शुरू नहीं करना है, इसका एक सीक्वेंस है. ठीक है, सबसे पहला वेजोप्रेसर क्या करोगे? द फर्स्ट वेजोप्रेसर दैट आई विल टेक इज गोइंग टू बी नॉरएपिनेफ्रिन. इट इज द फर्स्ट वेजोप्रेसर ऑफ चॉइस. इट इज द फर्स्ट चॉइस. और नॉरएपिनेफ्रिन कब, whenever you don't know, we have to have some target that you have to keep. The target is going to be a mean arterial pressure of more than or equal to 65 millimeters of mercury. नॉरएपिनेफ्रिन स्टार्ट करने के बाद अगर पेशेंट का मैप 65 पे मेंटेन हो रहा है तो आप नॉरएपिनेफ्रिन पे रह सकते हो, कोई दिक्कत नहीं है. ठीक है. अच्छा, if the patient is not able to maintain the map at norepinephrine, what is the second one? The second one that you can give is going to be epinephrine. The second vasopressor that you can start is going to be your epinephrine. And the last one that you can give, you can add vasopressin if the map still not increases. So third क्या है? Third, you will continue the patient on epinephrine. Epinephrine के साथ साथ you can add the vasopressin. So first I'll start with norepinephrine. बात नहीं बनी तो epinephrine चालू करेंगे. Epinephrine से बात नहीं बनी तो इसमें हम vasopressin add करेंगे. And the last alternate that you have, अगर vasopressin, अच्छा, if you don't want to give epinephrine, so you can give as an alternate as dopamine. ठीक है. So you can give dopamine, but current recommendation of dopamine, no, dopamine आप उन patient में रहोगे where you have patient who has a risk of tachyarrhythmias or bradyarrhythmias, right? So either if there is increased risk for tachyarrhythmia, if there is increased risk of tachyarrhythmia, or if there is relative bradycardia, तब आप epinephrine के लिए नहीं जाओगे, you'll go ahead with dopamine. So the current indication for dopamine, if the patient has increased risk for tachyarrhythmias or relative bradycardia, then you will go ahead with epinephrine or vasopressor. ठीक है. So this is the treatment algorithm that we follow, and this is the target that we are going to keep in our head when we are resuscitating our patients. As simple as that. ठीक है. इससे ज़्यादा दिमाग लगाने की ज़रूरत नहीं है. दिस इज़ योर मैनेजमेंट ऑफ सेप्टिक शॉक. पेशेंट को इस क्राइटेरिया, इस दायरे में रखोगे, योर पेशेंट विल बी हैप्पी, एवरीबडी इज गोइंग टू बी हैप्पी. ठीक है. सो व्हाट विल डू इज, we'll talk about the fluids that we have. So अभी मैंने IV fluids के बारे में बात किया. Quickly we'll talk about the composition of the IV fluids. So this slide is also going to be very, very important. We'll talk about the composition of the IV fluids. So when you talk about the composition of the IV fluids, usually whenever you go with IV fluids, the usual components that we have, it is going to be sodium. We'll look at potassium. We'll look at the calcium. We'll look at the chloride. We'll look at the lactate. And we'll say if anything extra is there, that is the others. Or additionally, what do we have? Okay. The composition of IV fluids, you will have sodium, potassium, calcium, chloride, lactate, and others. Okay. So one of the most famous one that you have is going to be the Hartmann's solution. So when you say the Hartmann solution, how much amount of sodium is there? It is going to be 130. All these is going to be milliequivalents per liter. Okay. 131 milliequivalents per liter. Potassium is going to be 5 milliequivalents. Calcium is going to be 2, chloride is going to be 111, lactate is going to be 29. There is nothing specific other than this. This is what we call it as the Hartmann solution. अब Hartmann solution को usually हम confuse कर जाते हैं Ringer lactate से. देखो, to be very honest, no, Ringer lactate and Hartmann solution are almost same, they interchangeable. लेकिन ये दोनों अलग अलग, you know, they were invented, so the names are different. Composition is going to be almost same. ठीक है. सोडियम 131 की जगह 130 मिलेगा आपको. पोटेशियम 5 की जगह 4.5 मिलेगा आपको. Calcium is going to be slightly higher, that is 2.7. Chloride is going to be on lower side, that is 109, and lactate is going to be 28. Nothing specific. ठीक है, ये छोटी छोटी चीजें जो ट्वीक हो जाती हैं between your Hartmann's and the Ringer lactate solution. ठीक है, फिर बारी आती है सबसे कॉमन वन की, हमारे नॉर्मल सलाइन की. So when you look at the normal saline, it will have only sodium and potassium. It is going to be 154 milli equivalents of sodium and 154 milli equivalents of chloride and nothing else. Okay? And nothing else. And this is your Ringer lactate. So this is your normal saline. Okay? So you have the Hartmann's, the Ringer lactate, and the normal saline. Then you have something called as the other less common one. This is your plasma light. This is going to be the plasma light. Plasma light, sodium is going to be 140 milli equivalents per liter. Potassium is going to be 5 milli equivalents per liter. Chloride is going to be 98. Now, what do you have in plasma light? You have acetate. Additionally, you will find there is presence of acetate is there. There will be magnesium will be there and gluconate. You don't need to know the composition of these. I don't think they'll ask you. But three important components that are found other than its electrolytes are going to be acetate, magnesium, and gluconate that is going to be present. Another one that you will see is going to be HemaSeal. Now, HemaSeal is something that we will use in our regular OTs also as a replacement for blood products. So HemaSeal, you have sodium of 145 milli equivalents, potassium of 5.1. Calcium is usually less than 1 milligrams that is going to be present. This is going to be, chloride is going to be 145. Now what additional that you have, it does not have any lactate. It does not have any lactate, but what does it have? It has got something called as polygelatin. It has got it is a polygelin or not gelatin, it's polygelin, which is going to be at 75 grams per liter is what is there, is a polygelin. Okay? So this is what you have in HemaSeal. Then you have the Heta starch. Then you have something called as the Heta starch. This is your Heta starch, right? So here in Heta starch, you have the HIO, that is high oxyethyl starch, which is going to be 6%. So it does not have any of these components. It does not have any of these components. The only thing that he has is hyoxy. That is high oxy, not a high oxy. High oxyethyl starch. It has got high oxyethyl starch is going to be present. Okay? High oxyethyl starch is going to be present. It is going to be high oxyethyl starch. Another fluid that you have is your DNS, that is dextrose or dextrose with normal saline. So you have dextrose. So you have dextrose 5%, 10%, 20%. So what does dextrose basically consist of? It consists of 30 milli equivalents of sodium, 30 milli equivalents of potassium, and it consists of glucose, which is going to be at 40 milligrams per deciliter. 40 milligrams per deciliter. So this is your dextrose fluid. Okay? So these are the various fluids that are present that you should be aware of. So IV fluids and their compositions are very, very important from our exam perspective. So I try to keep it very simple so that we can remember all the important components. So take a look at it. Every single component is important. I'm not done yet. I'll give you a little bit more data about it. It is about the pH. Okay? So again, if you have attended my regular lecture, you would have known that I will emphasize on the pH of these fluids in order to make a choice that when do you want to give which fluid. Okay? Again, a very, very important prospect. So all these are the composition or the fluid composition that you should be aware of. Okay, so this is about the various compositions of the fluids which are going to be relatively quite important. So when you look at the pH, no, quickly looking at the pH also. So when you look at the pH of the Hartmann solution, so we'll just add one more small tweak here. So we'll add the pH of this, right? So pH of the Hartmann's solution is going to be 6.5. Ringer lactate is going to be 6.5. Normal saline is going to be your 5.7. And you're talking about normal saline is at 0.9%. 0.9% is going to be at 5.7. Usually they will not ask osmolality, but if they ask you what is the osmolality of the Hartmann's, remember the osmolality of Hartmann's is going to be 270 milliosmoles per liter. Ringer lactate is also going to be 270 milliosmoles per liter. Normal saline, it is going to be 308 milliosmoles per liter. It is going to 308 milliosmoles per liter. If you look at the plasma, no, plasma composition, I'll just add at the end for the sake of understanding. Whenever we'll talk about plasma, right? Plasma has got 140 milliequivalents of sodium, 103 milliequivalents of chloride. Potassium would be 4. Calcium would also be 4. It will have magnesium of 2. Magnesium is going to be of 2, and then is going to have a bicarb which is of 25. Bicarb which is of 25. You will see the pH that you will see here. The pH is going to be 7.35 to 7.45. So a single value is going to be 7.4. And when you look at the osmolality, it is going to be 290 milliosmoles per liter. This is just for our understanding that I have added this additional point. Okay. So this is comparison with the plasma. In comparison with the plasma, this is the fluids that you are going to give across. Okay. So this is the various components that you should know in the context of fluids as well. Now when it comes down to how do you monitor shock, right? So when you look at the monitoring shock, again very, very important. So talk about how do you monitor shock. So indices to monitor shock. That is, any patient who has landed up with shock, how do you know that whether that particular patient is responding to our treatment protocols or not? That is indices to monitor shock, right? Now the first index that you will monitor shock is going to be something called as the shock index. Now how do you measure shock index? Shock index is measured as heart rate upon systolic blood pressure. It is going to be heart rate around systolic blood pressure, right? Let's say we say normally the heart rate, it should be less than 100 and systolic blood pressure should be more than 100. In that case, the shock index that you will get, obviously the denominator is more than numerator, so it should be less than or equal to 0.9, which is considered to be normal. Okay. Just to give you a rough estimate, how do you look across here? Now to give you a better objective, on the basis of shock index, the normal shock index is less than 0.6. Patient is considered to have mild shock if the index is anywhere between 0.6 to 0.9. Patient is considered to have a moderate shock if it is more than or equal to 1, and patient will consider to be having a severe shock if it is more than or equal to 1.4. Okay. So this is on the basis of shock index. Okay. But again, what did you do? You did a small mistake here. The mistake is taking systolic blood pressure, because we know the pressures are of two components, systolic and diastolic. You have to take both. So hence now we have something called as modified shock index. Now, in the modified shock index, what did we modify? We kept the heart rate as it is, but this time, rather than taking systolic blood pressure, we took mean arterial pressure, right? So again, if you look at it, the heart rate should be less than 100 to consider as normal, and the mean arterial pressure is anywhere between 90 to 110 millimeters, which is considered normal. Okay. Again, if you look at the ratio, comes almost to the similar factorial, but we say in the modified shock index, if you have a modified shock index of more than or equal to 1.3, then consider the patient is in shock. So my target is to bring down the modified shock index to be less than 1.3. The modified shock index should come down to be less than 1.3, as simple as that. Okay. So you had shock index, then you have modified shock index. Then the other things that you have, that another ways that you can measure, or I can say look across, is to measure the central venous pressure. We have already looked across it. Another one is your mixed venous oxygen saturation. You can also look for IVC diameter. It's an IVC diameter, and this is done on with the help of bedside ultrasound. Remember, a normal IVC diameter should be more, I'd say rather not more, it should be around 2.1 centimeters, right? And obviously, whenever you give fluid, this diameter should restore back. Less than that indicates of non-responsive shock. The last one that you have is urine output. It is a urine output. Okay. Now, if they ask you what is the best method to monitor shock, remember the overall best method to monitor shock. The best method to monitor shock. The best method to monitor shock is going to be modified shock index. But if I change the question, which is the best clinical method? The best clinical method. The best clinical method to monitor shock. The best clinical method to monitor shock is going to be your urine output. Okay. So this is how you look into the patients of shock, their management, and their protocols. Okay. So I try to break down all these components in a very elaborate fashion. We started our discussion today with the basic objective of the definitions of each individual component, that किसको sepsis बोलते हैं, कब आप septic shock बोलोगे, कब आप मॉड्स बोलोगे, क्राइटेरिया ऑफ सीवियर सेप्सिस क्या है जो आजकल वैलिडेटेड नहीं है, न्यू और ओल्ड का बता दिया मैंने आपको, सोफा स्कोर क्या होता है, हाउ डू यू कैलकुलेट द सोफा स्कोर, व्हाट इज क्यू सोफा स्कोर, हाउ डू यू कैलकुलेट अ क्यू सोफा स्कोर, अभी न्यू और ओल्ड क्राइटेरिया में फ़र्क क्या है, वी हैव गॉन थ्रू दैट, रिससिटेशन प्रोटोकॉल्स और हमारे गोल्स क्या हैं, कैसे रिससिटेट करोगे, कौन से आइनोट्रोपिक सपोर्ट्स लोगे, एट व्हाट पर्टिकुलर, दीज आर द क्राइटेरिया दैट वी हैव लेड डाउन, एंड देन ऑब्वियसली योर फ्लूइड्स, यू डोंट नो फ्लूइड्स, यू आर नो अ डॉक्टर. ठीक है, अगर आप अपने फ्लूइड नहीं जानते हो, यू नो लेस नो मोर, यू कैन नॉट बी अ डॉक्टर. यू नीड टू नो दिस डेटा, क्योंकि इसी पर डिपेंड करता है कि क्या देना है क्या नहीं देना है. इफ यू डोंट नो योर फ्लूइड्स, आई एम सॉरी टू टेल यू दैट यू विल नॉट मेक अ गुड डॉक्टर. तो यू शुड नो योर IV फ्लूइड्स, देयर एंटायर कॉम्पोजिशन, एंड कौन सा कब देना है कब नहीं देना है, दैट विल कीप ट्वीकिंग एज वी कंटिन्यू टू रीड. सो ठीक है, हाउ डू यू मॉनिटर शॉक, दिस इज द इंडाइसेस टू मॉनिटर शॉक that you need to understand. Okay. So this is all that I had for the lecture of shock today. Thank you so much for joining. Any questions, you can fire it up. But before that, all the FMG bachas who are writing their exam on the 12th of January, remember, it's almost there. Keep yourself cool, keep yourself calm. You have done amazing job. Have a little bit of self-belief, not little bit, you need to have a lot of self-belief, a lot of faith in yourself, and just go write the exam. Okay. Please do questions in these last 4 or 5 days that we have. Also try to revise your previous year topics as much as possible, but in a quick succession. Okay. So do well in your exams. And all those bachas who are writing your Neet PG exam in your June, that is mid-June 2025, it's high time, right? This is the most crucial juncture of your preparation. अभी से जो लास्ट के 4, 5, 6 महीने जितने भी अपने पास हैं, इफ यू टेक दिस एज ए कंसिडरेशन, अगर आप जान में हो, आपका जून है, तो हार्डली 5 महीने का प्रिपरेशन बचा है. दिस इज द मोस्ट क्रूशियल फेज ऑफ योर प्रिपरेशन. सो गेट योर हॉर्सेस रनिंग, fasten your seat belt, and now you need to work hard to get to your seats, right? With that, thank you so much. Signing off for today. We'll see you with BLS next week. Next week, we'll continue on the allied branches of trauma only. We'll have a lot more discussions on that. If you have anything else to suggest, please feel free to tell me on my Instagram channel. You can reach out. The Telegram and the Instagram, it is called as the Surgery Guy. This is by my name, that is your Dr. Sandeep Seeram Reddy. Any questions, any queries, you can reach out at any point. Thank you so much. Signing off for today. See you next week. Bye bye.